Okay, good evening, everyone. Welcome to the second of our AO North America Masterclass series, which is held on the first and third Thursdays of each month. My name is Metacarpal, and we have a phenomenal session planned for you today. I'm glad you could join us. For those of you who are joining us in North America, welcome. For those of you joining us on OrthoTV's platform, welcome to you across the world. A moderator for tonight is John Elfar from Penn State. And he's going to be moderating the session with Jeff Lawton, who's fielding the questions. And our master for tonight is Chuck Cassidy. John, all yours.
Good evening. Thank you. I just am going to go through a couple of slides. I want to welcome you all here. We're talking about one of my personally favorite topics. This is our chairperson who was just speaking to you. We're all kind of fortunate to be working with each other on this really cool talk. This is our master tonight, Dr. Cassidy.
Good evening.
And he's going to be talking about these very challenging.
I just am going to go through a couple of slides. I want to,
and I do have a case if no one else does at the end. So I guess I'm going to be functioning as the moderator. Dr. Lawton from University of Michigan is going to be handling our Q&A. It looks like we have a star-studded group already logged in. A couple of things we're supposed to go over. First, these are the disclosure informations. I'm sorry, these are the disclosures. This is the information slide on that. I also want to sort of go over a little bit of an agenda. We're probably going to be closing this out at around 8:10, 8:05, much of the much of the talk is going to be by Dr. Cassidy. To obtain CME credit for this, you have to go to this
Cassidy.
link, which you're going to get an email at the conclusion of the series. This is the content validations statement from the AO.
Cassidy.
A couple of things about Zoom etiquette. Probably everybody knows this. When you're not speaking, you turn off your camera and try to put your questions in the Q&A section. And the chat function is for us to scream at each other in text. So basically, without further ado, I'm sorry, this is the learner objectives for this AO talk, and they're listed here, and I'm sure they're all going to be met. This is the session we're in, the second one with the line crossed through it. So we're already at the second of the lectures in this series, and you can access the recording on AO North America. Without further ado, Dr. Cassidy.
Thank you very much, John, and thanks to all of you for joining us this evening. As you noted, I have no disclosures. Aside from this one, I owe much of what I know about this subject to my mentor, Dr. Jupiter. First of all, you have to realize that you don't have to do anything when it comes to phalangeal and metacarpal malunions. And this is sage advice. Acceptance of a mild or sometimes even greater deformity in a relatively asymptomatic malunion is preferable to operative correction with poor or uncertain prospects for significant functional improvement. Or this, from the same paper, corrective osteotomy for exclusively cosmetic purposes alone should be considered most judiciously. There are lots of dangers. So here are a couple of examples. So this patient with a malunion of the proximal phalanx, so the small finger. And this is what we see in the sagittal plane. We see an extension deformity. And we know from this elegant paper that we're going to get an extensor lag with this extension deformity. And this is clinically what it looks like. He's got a great fist, right? Flexion is for function. The answer for this, no surgery. Here's another one. This multiply injured patient who had this proximal phalanx fracture treated non-operatively. You can see there is shortening. And again, from this paper, we know that we're going to get about a 12-degree extensor lag at the PIP joint for every millimeter of shortening at the proximal phalanx level. But here she is clinically. So that's her active extension. Here's her passive extension, extends fully, great fist, no surgery. Keep those in mind. Don't let the patients convince you, because what they think they want, it may not be achievable. So we'll start with metacarpal malunions. Interestingly, in the last 16 years since we have had digital x-rays, I looked at osteotomies of the metacarpal and phalanges in my practice, and I have many more phalangeal osteotomies than metacarpal osteotomies. And the metacarpal osteotomies primarily are thumb metacarpal osteotomies for early arthritis or congenital. When it comes to metacarpal fractures, prevention is the best treatment. You can't just look at the x-rays, they may be deceptive. So here, this patient, you could see a slight pronation ulnar deviation posture, but with tenodesis that is magnified. So it's worse than the x-ray clinically. And from Jesse to Buddy tape, a malrotated spiral fracture. Here's a quiz. A, fools the doctor. B, does not reduce the fracture. C, rotates the MP joint. D, does not fool the patient. All of the above. You could see this patient with Buddy strapping and that rotational deformity that is not going to be corrected by strapping alone. Don't trust that. So why does a malunion occur? There are forces that go across the joint and the metacarpal. They're bending and rotational forces and anatomical forces such as the arch or the curve of the metacarpal, the force of the long flexors and the intrinsics, and suboptimal splinting or surgery potentially can result in malunion. So we'll classify these generally in terms of angulatory, rotational, and shortening. And then in terms of duration, nascent versus established. So how much angulation, rotation, shortening is acceptable for metacarpal? Well, really, what we consider unacceptable for an acute fracture may be acceptable when we're thinking about a malunion. So in terms of angulation, generally speaking, 10 degrees of angulation for the index and middle, 20 of angulation in the ring, and 30 in the small. So you can see for the small finger, it's less than what you would think of for a boxer's fracture. And the key is that the more proximal the fracture in the shaft, the more of an impact it will have in terms of translation of the distal segment. In other words, the metacarpal head will be further into the palm if there's a sagittal plane angulation that's originating proximally. 10 degrees of metacarpal rotation can produce up to a 2 centimeter digital overlap at the tip, and that has to do with the length from the length of the digit from the point of rotation. And then we know there's from a cadaver study, there's a 7-degree extensor lag for every 2 millimeters of shortening. And this shortening is not usually a problem because of the connections, the intermetacarpal ligaments, and maybe a problem if you have multiple metacarpals involved. So let's order a physical examination. Lateral angulation is better tolerated in the border digits, although it may be more apparent. So here's this patient. We can see this ulnar deviation and extension, but inflection lines up beautifully. Whereas malrotation is evident in flexion. So don't be fooled in extension. You can also look at the nail plates in extension, and I'll show you an example. So what's the big deal? Malrotation results in crossover and space distortion of that digit with respect to the rest of the hand. Angulation produces a dorsal prominence. You could see, for example, this guy's knuckle moved up. Loss of the contour, interference with power grip. If, for example, if you had a bad boxer's fracture, there'd be a palmar prominence that some people are bothered by, shortening of the intrinsics and cramping and fatigue, and a pseudoclaw or a PIP joint contracture over time. So here you could see this pseudoclaw up above with full passive extension. This was ulnar nerve, but the point is valid. And if that's left for a period of time, the patient will potentially develop a PIP contracture because of that deformity. So preoperative planning is critical. You have to plan the surgical approach, the skin incision, how to access the bone through the extensor mechanism, the osteotomy itself, fixation, and a postoperative rehabilitation program. So the key is to make this plan before you get into the operating room, make sure you have the equipment available. In terms of the deformity type, an angular deformity, you can get away oftentimes with an incomplete osteotomy. So you leave a cortical bridge on one side, and that could be done via an opening wedge or a closing wedge. Rotational malunion requires a complete osteotomy to derotate it. Same thing with a length problem, and the same thing with the combined. So the first one you can get away with hinging. The others you need to complete the osteotomy. So where to do the osteotomy really depends on the duration. So ideally, you'd like to do it through the original fracture plane, but after a couple of months, the bone is healed in that site, especially in a rotational malunion, it's hard to follow the plane. So after 3 months, an osteotomy at an away point with either in the metaphyseal region where there's a broader surface area or a diaphyseal step cut may be more appropriate. So we must be able to control rotation and angulation. There's not a lot of room for plate fixation. We would like to have it low profile if possible. We want to have a large surface area, and we want to allow for early rehabilitation. And we have to think about these issues. So if there's a joint that's affected because of this malunion, whether we do a capsulotomy at the same time, if the tendons haven't been gliding, tenolysis, and if there's a nerve issue, nerve graft. But the key is motion after fixation. So that really trumps the others. So whatever it takes to get the motion. So here we have an established extra-articular angulatory malunion. Do we do an opening wedge or a closing wedge osteotomy? So it really depends on the degree of bone shortening. So if it's already short, it's better to do an opening wedge. And if you do that, if you put a structural bone graft on the side opposite, so that in this instance, it would be on the volar side, it's going to resist bending well, and you can use a lower profile plate. If the bone length is adequate, you could do a closing wedge, which is technically a simpler operation, doesn't require a bone graft and lower profile plate. So if you have a malunion and extension, an opening wedge with a small plate and cancellous graft. If you have a malunion and flexion, an opening wedge with a larger plate, or you could get away sometimes with a thinner plate and a structural graft where you put the cortical part of the corticocancellous graft matching the volar cortex to resist bending. So here's an example of this malunion here treated with a opening wedge and a structural graft you see there in a relatively low profile plate. One thing I want to mention is if you're doing an osteotomy, for example, on the ring finger, you have to be careful with small diameter screws such as 1.5 millimeter titanium screws because you can shear them off if the cortex is really dense. So you're going to use a 2 millimeter plate in general or larger. This is an interesting technique for a malunited boxer's fracture. I've never done this, but it's intriguing to me. So here in the sagittal plane, make an extension osteotomy, and then fill in the gap volarly and use K-wires as an internal-external fixator, as you see here. It's an elegant technique that I'm going to try someday. How about an extra-articular rotatory malunion like this? What not to do is that. That is what we call an OIF. I have no idea what happened with that one, but 2 non-locking screws in a plate are not going to control rotation. So plan it out, make sure the plate's lined up properly, and at least a couple of screws on each side. If we're doing an extra-articular osteotomy, and it's been some time, we have a couple of choices, as I mentioned. We could do one at the base where there's a broad surface area, or we could do a step cut and thereby create a broad surface area. This is from Randy Bindra. So here's a patient with a ring finger metacarpal malunion and a technique So K-wire perpendicular to the shaft distally as a joystick, and you can get a rotatory correction of up to 20 degrees. And you can transfix it. So rotate it, transfix it. As you see here, put a plate on it, and there you go. So if you pre-plan, you can drill the proximal screw holes first, and it minimizes the number of steps later, moving parts later. There is a plate that allows for a rotational osteotomy through a transversely oriented slot, and that can be of use as well. So here, again, the goal is to minimize stripping, allow early range of motion. You don't want to mobilize the digits. Here we have another one, extra-articular rotatory malunion, the index finger. This is an elegant technique, and you have to think a little bit about exactly what you're doing, but if you have a 2 millimeter dorsal cortical resection, essentially hinging on the volar cortex, you can achieve about 20 degrees of correction. And so this slide, you got to spend a minute on this one. If you have to think of which the direction we want to correct. So if the digit is pronated, for example, the distal cut, transverse cut, is going to be toward the little finger, like that. And supinated, you can see the nail plate. The distal cut is going to be toward the ring finger, so toward the deformity. And make sure you draw this out before you actually make the cut when you're doing it. I still draw it out. And so here, for example, you make a partial osteotomy distally in the plane, approximately opposite side, and then take out that cortical wedge and then clamp it down. There you go. The maximum amount of correction you get is about 20 degrees, and it turns out to be a little bit less clinically than what you achieve on the metacarpal itself due to some soft tissue constraints. But here it is, close it down, bang. This is a trick that I came up with for an osteotomy. If you don't need to correct too much, if you take a blade and you alternate the tines of the tip to widen the kerf of the blade, so each tine is going in a different direction, alternating, you can cut a wedge of bone out all in one step rather than trying to make two cuts that are really, really close together. Alternatively, some systems allow for stacking blades. You could stack two blades together and do the same thing. So here's that example. So that was that finger. It's a lot of fun to do. Clamp it down, put 3 screws across. Ideally, you want to get 3 and let them start moving right away. Here we have a malunion at the base of the ring finger metacarpal. There it is. You can see it supinated and lined up perfectly in this instance. I think this might have been Dr. Jupiter's two screws. And this combined angular and rotatory malunion, this one conceptually is a little more challenging. You can certainly define, if you're really good at deformity correction, define a single plane to achieve simultaneous correction of angulation and rotation, or you can make a transverse osteotomy and figure that out later and cheat a little bit. So here you can see the nail plates slightly off to the right, and flexion gets markedly more magnified. And this is what I did here. This was actually not very easy to achieve, but came out pretty well. It's the osteotomy is proximal enough that it didn't really interfere with the extensor function, and that's how it looks. So up above, pre-op, down below, post-op, in full motion. Next, intra-articular malunions. These can be really challenging, and I just want to show a couple of cases that kind of sort of simplified challenging problems. So here's a guy who had a crush injury to the index and middle fingers, and he had this index malunion, and limited. His principal complaint was limited MP flexion, and you can see something's not right in the oblique view. It wasn't rotational, but so there was a chunk of bone that had got pushed into the retrocondylar recess adjacent to the collateral ligament that was blocking flexion. Otherwise, the alignment was actually pretty good. So no need to take the whole thing down and just access the joint here. We did it through a dorsal radial approach. So he needed obviously a capsulotomy because he had that contracture. So a transverse capsulotomy at the MP level, and then coming around to the radial side, volar to the collateral ligament, and then just doing an ostectomy of that primarily non-articular portion allowed restoration and just simplified more challenging, potentially challenging problem. And here's another one. An intra-articular metacarpal malunion with MP locking. So this woman she'd make a fist and then her finger would not come back up. And you could see the double density there. And here in the sagittal plane, you can see that step off. You can see the beak. So what's dorsal is actually where it belongs and what's volar got pushed in. And here's a CT scan and then their clinical photo to the right. So that's inflection. So dorsal's up. And you can see the dorsal half is where it belongs. The volar half is underneath. That's not so easy to access. And so there are a couple of choices with this. So we can either make it the way it used to be, which would require an osteotomy in this plane, and then sliding the head distally to match up with the dorsal part, and then fixing it, or doing it from above, which technically is quite a bit easier. So retaining the collateral ligament attachments and then taking a wedge of bone out proximally and then just sliding the dorsal half to match up. And so here it is intraoperatively. So we took a wedge of bone out dorsally and then just slid the head through the original fracture plane, slid it proximally and just fixed it. And that's what it looks like, and solved a challenging problem in a relatively simple way. So I'd like to stop for a second, and maybe if any of my partners on the panel have any suggestions, questions, thoughts.
Chuck, no questions. The one thing that metacarpal osteotomy is a great technique, and you said that the one where you make the longitudinal cut and then secure it with 2 or 3 screws. One thing to try to help you figure it out is to do it on a paper towel roll or a toilet paper roll, and experiment and make the cuts one way or the other way, and then see which way it goes, and that can really help you see it. As you said, drawing it out is another way, but sort of doing it on a paper towel roll is handy.
That's a great idea. So during the height of COVID, there was a shortage of.
That's right. Lack of metacarpal osteotomies with no toilet paper, but
we had a dry spell then.
Well, some of us saved up all our toilet paper rolls.
You guys. So no questions. Please, participants, feel free to post questions, and either Jeff will respond or we'll address them later.
No more toilet paper analogies, I promise.
Okay, Jesse's on today. Jesse, got any comments?
Yeah, make a point. When you talked about how to judge intraoperatively, if you take small K wires and put them proximal to the malunion, perpendicular to the shaft and the sagittal plane and in the frontal plane, and then do the same distal to the malunion, again, perpendicular. When you do the osteotomy and line up the K wires, you'll be able to judge your correction very easily. You follow that?
Absolutely. And I do it, and I forgot to include it, but thank you for reminding me. Yeah, that's it. You got to do that before you do your osteotomy, and make sure they're out of the way of the planned fixation. Awesome.
All right, Chuck. So one question you sparked interest, and I'm going to paraphrase and expand. The question is, do you recommend ordering CT scans and metacarpal malunions? But maybe when do you feel that plain films are enough?
Yeah. So I think what the patient is experiencing is the clinical deformity. When it's an extra-articular malunion. So I don't routinely get CTs for extra-articular malunions, but if it's an intra-articular malunion, absolutely. So if it's at the base into the CMC joint or distally, I would get CT. CT is very helpful at that level. As you get more distal, it's hard. Like, at the DIP joint, there are only really a couple of cuts that are worthwhile, but at the MP and CMC joint level, definitely I would get it. All right, on to phalangeal malunions. And as I mentioned, these are, at least in my practice over my career, these have been more common and more challenging. So conceptually, an osteotomy through the original fracture plane makes sense. Timing, however, is critical, and the soft tissue challenges are different than for the metacarpal. So in the metacarpal, there's the peritoneum around the extensor tendon. There's a little bit of space, and there's a lot more motion than over the proximal phalanx level. So I'm not going to talk about hemi-hamate today. So I know that many of you in the audience were looking at this and saying 2 months, hemi-hamate. But this one, it's a little bit different. It's got a very big metaphyseal component. There is some central impaction, but big pieces, and the dorsal part looks okay. And so this one, I actually attacked from a dorsal approach, well, dorsal skin incision, I should say, and then went around the sides. And then, retaining the collateral ligaments, and disimpacted that impacted central segment and fixed it with a few screws. And so for those of you who have trepidation about doing the shotgun approach to attack these, this is of value. So coming around the sides to access it, you got to respect the collateral ligaments, because the blood supply to that proximal aspect of the middle phalanx is coming from the collateral ligaments. So this one was a win. Again, big pieces though. This one is an interesting one. So here, this is a patient who had a healed ring finger proximal phalanx fracture. And on the PA and lateral views, it doesn't look so bad, but on the oblique view, look at this. It is, it's crazy, right? So that's an oblique view of the hand, but essentially a PA view of the distal part of the digit. And so this was how it looked. And that's how I fixed it. So I made a proximal osteotomy, so at an away point, and fixed it. And that is one where I probably today would do a metacarpal osteotomy. We'll talk a little bit about that. But intuitively, it's in the phalanx. You want to fix it in the phalanx, but you introduce some issues with respect to the extensor mechanism. And you can see here, this is the telltale sign of an extensor lag. Is the pencil pushing up on the finger on the lateral view, so the patient can't maintain extension. And that hardware is pretty bulky, and I ended up taking it out later. So here's another patient. You can see ring finger proximal phalanx malunion. It's pronated. So that metacarpal osteotomy that we had talked about a little while earlier is a great option. So if it's not really a multiplanar deformity, if the shortening is acceptable as primarily a rotational problem, the metacarpal osteotomy is a great way to get around that. So rather than go through there to do this, it's really elegant. So again, if the digit is pronated, the osteotomy comes out on the ulnar side, like that, and draw it out. Use a toilet paper roll. Definitely draw it out before you do it. Supinated the other way. So here it is, an intraoperatively long osteotomy. So to get fixation, at least 2 screws, hopefully 3 screws. I like to have enough room where I can put a clamp on either side, and then just gradually, don't try to clamp it down all at once. And it's really helpful to use a beaver, like a 64 beaver blade. You can use it as an osteotome and just tap, 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 or just drill a few with a fine K-wire holes to perforate longitudinally the volar cortex. So you don't dissociate it completely, and then just clamp gradually, proximally and distally, not all at once. clamp it down at both ends, put a screw in the middle, and then you can get a screw on either side. Take the clamps off sequentially. And so there it is. And that's how it looks. And you can see how long that osteotomy was. It was beautiful and came out great. And now for something completely different. This is courtesy of Chai, who's the king of intramedullary small bone fixation. This is a patient who had a proximal phalanx malunion of the index finger. You could see it's pronated and angulated. And so the preoperative plan, like we had talked about, so this is a lateral closing wedge rotational osteotomy and internal fixation with a headless screw and tension band. And we'll talk more about that at the end. I can interject. So this looks lined up beautifully, as you see here. How about intra-articular malunion? So intra-articular malunions, as you get into the more distal part of the digit, you get more and more and more complicated. So here's a patient who's very young, who has this intra-articular malunion. You can see on the lateral, it looks like at least part of the head is dorsal to the shaft. The ulnar condyle is short. And so the question is, in this instance, do you take it all apart, put each piece back together again, which could risk devascularizing fragments, or do you fix the articular deformity and maybe leave a slight secondary deformity? So someone had asked about a CT, articular fracture, malunion, definitely get a CT. So I'll show you some select cuts here. So this is coming from the dorsal side. So I'll go back for 1 second. So you can see there on your right is that condyle that's spun out dorsally. There it is. And the volar spike of the retrocondylar recess blocking flexion. So this patient had virtually no motion at the PIP joint. And then coming around there, you could see that spike will go back right there. And the ulnar, the other condyle looks lined up pretty well. And so in this instance, I chose to accept the slight shortening of the larger condyle that was otherwise well aligned and fix the retrocondylar spike and the smaller condyle. So a curvilinear incision, key, make a curvilinear incision, not a straight one. And then expose the extensor mechanism. You can see the triangular ligament there. In this instance, we did a modified Chamet approach. And so instead of using a distally based triangular flap, I like to use a rectangular flap. So you can see extending proximally from the margins of the central slip. You extend the incisions longitudinally in the extensor mechanism and then transect it proximally. And I do it pretty proximal and then flip it up and try to leave the periosteum intact. So just get through the extensor tendon. What I do is make a little slit and take that angled probe and lift up the extensor tendon so that the resident or fellow is not cutting the periosteum as they're incising the extensor tendon. And then flip it back so you can see here. And their condyle, you can see how it's now rotated. There it is. Had to dissociate it. Again, leave the collateral ligament attached. The risk of avascular necrosis of that condyle is pretty high. So you have to respect the soft tissue as much as you can. And then clear out the callus in between. So we've left the ulnar condyle attached to the shaft, and there's the spike. And so we're going to nibble away at that spike to allow for flexion. And then clamp down the small condylar fragment there, as you see there, line it up. And so it's going to look a little bit funny because we're accepting that slight deformity of the larger condyle, which is fine with me because I want this to move right away. And I don't want too much hardware to be in there. And you can see in the lateral, he's got 90 degrees of flexion. So we've cleaned out the retrocondylar recess, and that's how it was stabilized. like that. It looks good. As you can see, a little extensor lag with the pencil tip at the digit on the lateral x-ray, but came out great. So a combined intra-articular and extra-articular malunion. So this is a real challenging one. So if you're into deformity correction, the cora, the center of rotation of angulation is in the joint. So you can see that this is a chronic problem, and the joint is subluxated slightly ulnarward in addition to the coronal plane angulation. And that is something in a young person that we can't fix. So this was somebody in his late teens who had had this injury a few years earlier. And so we did an opening wedge osteotomy on the ulnar side. You can see with the little tension band like Chai used before. I tried to keep that cortex intact, bone grafted it as you see here, and he did pretty well. Not perfect by any means, but it's better to try and keep things a little bit simpler sometimes to allow them to move it. And accept a double in some of these instances because the risk of trying to achieve a home run is pretty daunting and fraught with complications. So we'll talk a little bit about phalangeal non-unions. So think about your preoperative plan. You want to try not to shorten if you can, because we had talked about the extensor lag associated with shortening. Just like any non-union, we have to prepare the bone ends. You can see the sclerotic ends. So we're going to have to open up the canals as part of the treatment, find some healthy bone, autograft, stable fixation. So this was fixation out of plane. You can see the plate dorsally, but I also put crossed oblique K-wires to help to stabilize it, and then early motion. And then this technique for compressing a bone graft, I learned from Dr. Jupiter, where you can pack the bone graft in a syringe, compress it, and then take the plunger out and pop it out with a K-wire. And then you have this beautiful, looks like an eraser head that you can stick in there. And that worked out well. Here is a 20-year-old college ROT student who shot himself while cleaning a weapon. That's a bad sign for somebody who's an ROTC student, but pretty dusted middle phalanx. You can see intra-articular fracture, bone loss, had a nerve injury as well as a soft tissue injury. And so here's a traction view, and you can see there's multiple articular segments, and then the metaphyseal bone loss. There again, simplify it. One option would be a bridge plate. These days, we've been putting bridge plates on the radius for a while, and I've done it on fingers. In this instance, the soft tissue envelope wasn't ideal for that, but something to consider in another situation. Interestingly, it was percussive injury to the digital nerve. As you see there, the digital nerve is intact, looks contused, and ultimately came back almost fully. But that's the defect on the exit side, as you see there. So I wasn't really up for a bridge plate on this one. So we did a rotation flap and an external fixator. So this is a biplanar mini X-fix. An X-fix that's a unilateral for something like this is not going to work. So you got to go either with all the way across the digit or pins coming in from both sides. And this is a masculate technique. So you can see the bolus of cement in the defect, but at least as important, I think even more important here is the restoration of the joint. So what we did is through that defect, we used the head of the proximal phalanx as a template and lined up that dorsal base that was being pulled by the central slip and the volar base that was flexed in that central portion, and just I actually went from the metaphysis through the defect through the head and then came out the other side. And so those are holding that alignment, which would not be held by the external fixator. And then we used iliac crest graft a month later. I left those pins in knowing that we're going to do some more surgery at a later date. Allowed that to consolidate. And we took the fixator off at 10 weeks and did an extensor tenolysis, a PIP capsulotomy, and a flexor tenolysis in the palm 3 months later. And this is how we ended up, which is that's pretty much a home run for that bad injury that he thought he was going to end up with an amputation. And thinking about salvage the PIP joint, don't forget about fusion. So for some really bad problems like infection or these fracture fragments that are not reconstructible, if it's not amenable to arthroplasty, not radial side, you're not going to do an arthroplasty like for the index finger, especially an arthrodesis is a good option. So what could ever go wrong? Do an osteotomy, it might not heal, right? So this is an interesting patient who came to me after having had 2 operations for malalignment, had an osteotomy, then a revision osteotomy with these thick plates. And this was at 3 months. And I saw him and he had no motion in his PIP joint, complicated problem. He was smoking. And I said, why don't you just work on your passive motion and come back in a few months. And he stopped smoking and he came back a few months later and his osteotomy had healed. So of a complicated problem, he simplified one, that's for sure, by stopping smoking. So my point is that the phalanges in the diaphysis don't heal that quickly. And so don't jump to revision surgery if the hardware hasn't failed. Keep them moving, give it some more time, have them stop smoking. This is a patient who came to me after, again, she had had a couple of operations. She had had a fracture of the proximal phalanx percutaneously pinned, and then that fell apart, and then had a plate fixation. And you can see that scab. Look at the scab over the head of the PIP joint, or the head of the proximal phalanx. That's how much motion she had right there. This is her x-ray. And so this was, again, potentially pretty complicated problem with, I wasn't sure whether that fracture was healed. But just as a technical pro, keep this in mind. So look at that. It's a relatively low profile plate, but fairly distal. And so this is when I explored her, I wasn't sure what we're going to find, but you could see that the plate had eroded through her extensor mechanism. So she had no central slip anymore. So she had this plate, question malunion, not non-union. Definitely it was a malunion because it was rotated. She had an absent extensor mechanism. Her extensor tenon was just stuck down to the bone and to the plate, PIP contracture, and flexor tendon adhesions. So thankfully, the bone was healed. Took the plate out, and we did an extensor tenolysis. I put this interposition material to help to keep the tendon from sticking to the bone, and then use the central slip to, a lateral band to reconstruct her central slip, and the contracture of the PIP joint. And forget about the flexor tendons at this point, as long as you can get full extension. And so we just pinned her in full extension for a couple of weeks, and then just had her start moving it, and she did okay. But those plates, especially distally, the extensor mechanism really thins out and is at risk of abrasion, attritional rupture. And so I'm going to get to one final point, and that is that prevention is the best treatment. So this I would say probably twice a year, I have a patient who who needs a flexor tenolysis from a proximal phalanx fracture treated surgically with percutaneous fixation. So this is one, it's a relatively young patient. You can see that the proximal phalanx fracture is translated and it's extended. And so the back wall of the flexor tendon sheath is disrupted by this fracture, right? The fracture is really angulated, and that's one I would say I would not accept. Again, what you do for an acute fracture may not necessarily be what you do for a malunion. But to me, this definitely warranted surgery. But again, the back wall of the flexor tendon sheath is the periosteum, and that is definitely disrupted by this fracture, right? So regardless of the treatment, the tendons must move. It's not a big fragment to fix with a plate. You could do it, especially with locking plates, you could do it. But you could also use percutaneous fixation. So this I fixed through with a transarticular pin. As you see, the MP joint's flexed fully. And this other pin was an intrafocal pin, actually, to control that ulnar translation of the distal segment and to get it back out to length. So we left the two pins in, but I do move them right away. So I put them in a cast. Their MP joints are flexed fully, but I allow them to move their interphalangeal joints. And this is how she turned out. So if you cast them out to the fingertips after you do that type of treatment, the tendon's going to get stuck. And so prevention is the best treatment. And that's it. Hopefully I have pointed you in the right direction. Thank you.
What an awesome talk.
Thank you.
Would you like us to? I only have one case. You have so many cases in that talk. Do you want to wait for questions now, or do you want to talk about another case?
I think we have a couple of minutes. You want to?
Yeah, John. Maybe while you're getting set up, I can.
We'll
yeah. So a couple questions, Chuck. So some phenomenal cases. There was you showed one that was a combined osteotomy and that extensor tendon issue, and you mentioned you interposed some kind of membrane between the healed proximal phalanx and the extensor tendon. What kind of interposition tissue was that?
It's an amniotic membrane that it's intended to resorb eventually, but keeps the tendon from sticking. We used to use silicone sheets. And which I think is great, but you can get a reaction from them. And, historically we used to take them out. Maybe Jesse would like to comment on that, but silicone was actually a pretty good material for as an interposition, but you don't really want to leave it in forever. So then it adds another operation.
And then you mentioned a number of times throughout in terms of your therapy, but can you sort of summarize how you look at which joints to move, which joints to immobilize, and then maybe your choices of fixation that allow different types of motion?
Sure. Well, so I guess priority number one for me is the wound, and so I typically, unless it's a tenolysis, I'll have them move right away. But say it's just an osteotomy, I'm going to immobilize those joints, adjacent joints, and then have them come back a few days later. So it's usually going to be maybe 3-4 days later, and then I'll take a look at the skin. If the skin looks good, I will allow them to move as much as I can the interphalangeal joints. So I had a slide on the DIP joint. So to me, the DIP joint's less important. If you have a malunion of a middle phalanx and you need to immobilize the DIP joint or even put pins across it, to me, that's not that. There's very little morbidity. They're going to lose some composite flexion, but the PIP joint is much more important than the DIP joint. So I want them to move their PIP joint. Then plus or minus their MP joint. So if you're doing like a capsulotomy for an extension contracture at the MP joint, you really need to keep them flexed down because they're going to pop back up right away if you're if you allow them to rest in full extension. So my preference is to block them down at the MP joints and then have them move their interphalangeal joint, which will generate some motion, some gliding of their extensor mechanism more proximally. And then when I feel comfortable with the swelling, then I'll allow them to be extended and make a dorsal blocking splint, holding them down. But as you know, when the hand gets swollen, the MP joints tend to want to ride up into extension, and you have to resist that. So I'm not sure I answered the question, but definitely in conjunction with the therapist, right from the outset, and these complex procedures, I think just leaving it to the patient is not going to work. That being said, those metacarpal osteotomies, those I think you don't have to do a whole lot for them. They tend to do really well as long as their joints aren't contracted preoperatively. And I just tend to splint their wrist and buddy tape them.
All right. And then you showed a little figure of 8 tension band, and I know Chai's case, any issues with that in terms of needing to remove that being prominent, et cetera?
I would say on occasion you do need to remove them. What I like to do is I make a little trough with a small rongeur and bury the knot. So I think you have to think strategically about where the knot's going to end up before you tighten it, and then just what I do is I pre-bend it. So I make it short enough, bend the tip. So I have 2 needle drivers, one that holds the tip and one's that's adjacent along the knot. So I bend it so I get a little curl at the tip, and then rotate it in so the tip's not sticking up into a little trough that I've made. And it's not often that I've had to take them out.
All right. And during your talk, you teased the audience about nowadays. Sorry.
I was wondering if I could.
Sure, absolutely.
When the question came up about implant and tendon, et cetera, when you're faced with a particularly phalangeal deformity, if you do an osteotomy in the face of adherent tendon or adherent joints and not release the tendons and joints, you won't be able to get a decent amount of motion. But at the same token, you need to have an implant a little larger in size than you would for a fracture, because it's getting more stress at the osteotomy site. So to just do an osteotomy is without releasing the soft tissue contractors doesn't gain you much at all. You really ideally do them all in conjunction with each other, but be wary that you'll have to take the implant out and maybe do another more tenolysis, but you need a larger implant in general.
Yeah, I agree with that. And especially, so for example, I think about elbows and contractures and fixation, and you don't want to have a lot of resistance in the joint because it's going to put more stress on your osteotomy, right? So ideally, you'd like to have the joints gliding well. And I would say that locking plates are a big advance in terms of managing some of these fractures, especially if you're doing something proximally in the metaphysis, where the standard T-plate, if it's non-locking, doesn't provide great translational control. Whereas if you put a couple of locking screws in there, you get much better control over what's happening. I know that I didn't get into the surgical approach, whether to take some of the lateral band, one of the wing tendons, and put the plate along the side as opposed to dorsally. I think ideally for me, I'd rather put it where mechanically it needs to go and worry about, the tendons later. So I don't, unless it's like in the supracondylar area, I'd rather primarily put the plate dorsally.
I have put the plate laterally on occasion. I think when I do that, though, I really do like to take one of the lateral bands. I think it just sort of is asking for trouble, at least in my experience. If I leave that plate laterally, to leave a lateral band over it, especially since the finger works pretty well without it. So I have historically, if I have to put a plate on laterally, I take that lateral band.
Yeah, it definitely enhances the exposure. I worry about the central slip, and if you're losing something, central slip reconstructions are not great operations. There was a paper that came out recently using a tendon graft, which is through the bone, which is kind of intriguing. And it's sort of like a yoke, the way it's constructed through some bone tunnels. But in general, patients don't get great motion after you do a central slip reconstruction. So I try to leave this, protect as much of the extensor mechanism as I can over the proximal phalanx level.
And Chuck, you sort of teased in your talk about transition, your thought about when you might do a metacarpal level osteotomy for a phalangeal problem versus a phalangeal level osteotomy. Do you want to elaborate on that?
Sure. Yeah, I think we have to subdivide the deformity, or I guess define the deformity. So, rotational fractures tend to be accompanied by some degree of shortening. And if the shortening is nominal, then you can forget about it and just focus on the rotation. Right? If there's an angular deformity, the angular deformity is not going to be corrected by a metacarpal level osteotomy either. But it's such an elegant approach to deal with a difficult problem. Making an osteotomy at the metacarpal level, they don't get stiff. And rarely do you have to take the hardware out. Whereas over the phalangeal level, it's problematic. I showed you a couple of examples of bad problems that can occur. So I try not to. But if it's a multiplanar deformity, you got to go where the money's at. And the patient, in the end, isn't concerned about the X-ray. They're concerned about how their finger looks and how it moves.
Should I put up a final case or no?
Yeah, that'd be great. Thanks, Jim.
I have this case with great pictures from Tom Kiefaber, and I love this case. I think all of us have seen this kind of problem. I see this a fair amount now. So this is a 28-year-old architect, and this is a ways out from the injury, at least 7 months, 10 months, maybe even a year. And he's complaining of the appearance of this finger, has suffered this particular injury playing basketball. Like many of us playing sports, didn't really focus on it, hurt him for a while. And he's here with this scissoring. It's an index finger injury. X-rays are showing this intra-articular malunion at the PIP joint. So I guess the question I was going to ask the group is, what would you do? And then the second question I'm going to ask is, how would you approach it if you did something?
I guess I would start with one of our participants astutely asked about CT scan. And to me, it would be nice to have a CT to better define what the deformity is.
We don't have a CT scan in this. I do agree, because if there's any flexion or if there's any comminution, for example, in that, it's much easier to see on a CT scan. And I think if I did this case today, when I do these cases today, I do typically get CT scans unless it's a very clean fracture line. This one did not. And I think we can assume for this case, I'm going to show you a picture in a minute, that it was a single piece. It was a single sort of condylar piece that was off. This piece here, what the CT scan would show is that this piece is stepped down about, I don't know, a millimeter or so, and it is rotated off plane just a little bit as well.
Right. So like we had talked about earlier, the index finger is not a great digit for arthroplasty. You included that as one of the options. And
yeah. Really bad finger for us.
It needs to be able to resist lateral stress, and silicone doesn't work well. I have used pyrocarbon in the past. On occasion, there's an off-label approach which you could do as hemiarthroplasty. You could resurface the head of the proximal phalanx, which I've done, but I'd rather avoid that. It's so that's one. Two is the the average arc of motion of somebody who has an arthroplasty of the PIP joint is 55 to 60 degrees. And this guy has more than 60, I think. He's 65, I think. So 15 to 80 or something like that. He's not going to get 15 to 85. Yeah, the average patient after arthroplasty is not going to get as good motion as what he has. So he won't be happy with that. You could correct the deformity temporarily with an arthroplasty, but again, that's off the table. Arthrodesis, it doesn't sound like pain is the principal issue for him. Yes, some pain, but he's got great motion. I could tell you, he's not going to be happy with an arthrodesis. And it looks like a relatively simple malunion. So it looks like there's some gapping. So as you said, yeah, it's short, it's rotated. There's some central gapping so we're going to have to access the joint somehow to clear that space out to be able to derotate the head, the ulnar condyle, and match it up. You don't have to go all the way back. You don't have to go through the original plane, though. You can do that osteotomy more distally and simplify it, and with just a couple of interfrag screws. Again, you want to keep the collateral ligament attached to the ulnar condyle so you don't devascularize it.
Yeah. You agreed, Jeff?
Well, I was going to say, so just to play devil's advocate, so you could do an intra-articular osteotomy, or as he's got a 70-degree arc of motion, it's not in the plane that he wants and it's rotated. So you could go extra-articular, correct, do a radial closing wedge, and then through the transverse cut, correct your rotation and dial that in. And that, it's certainly not going to get him any more than his 70-degree arc of motion, but I'm not sure that he's going to get more with an intra-articular osteotomy either. And then you don't risk devascularizing that condylar fragment.
Yeah, I guess I worry a little bit about the longevity of the joint too. Which
the two
wouldn't correct
condyle,
that.
We're pretty well aligned. I mean, if they were stepped off, I wouldn't even think of that. But as they're aligned with each other and just out of plane, I think it's an opportunity.
Mm-hmm. I think that for me, when these patients come in, they don't use the word scissoring, but this bothers them. The sort of appearance of it, the functional problems with it. There's a certain amount of malrotation that a patient can just get their other finger in front of the injured finger and right the alignment. But beyond that, I think that this in my hands, if it comes in 100 times, it's probably going to get an operation. My one question is, how would you approach this? This is something you'd approach dorsally, or would anybody go in laterally? I personally would go in dorsally, and for this kind of injury.
Yeah, I think it is interesting. You could go volarly too, but if you did that, you'd have to release the collateral ligaments, which is not a good idea because you could devascularize it. But you could shotgun it. I would not do that. I would make a dorsal curvilinear incision, go between the ulnar lateral band and the central slip, and then go underneath the ulnar lateral band. So that would be two windows to the joint. Back to Jeff's point. So I kind of look at it as there are rails. So the radial condyle is where it belongs, kind of backwards, but then the ulnar, for that to be pronated as much as it is, so the ulnar condyle has to be dropped down, right? It has to be volar to and slightly proximal to, like that. So that they're on different tracks, essentially, right? And so I kind of get what you're saying about it's intriguing to think about doing.
Right, and that's why he's malrotated. It's not inherently malrotated. It's just because those condyles are out of phase with each other.
Right.
But
so
you can sort of adapt to that out of phase, take advantage of it, rotate it, and basically leave the joint the way it is and just put it in the right plane.
I think it's a highly congruent joint. I think like for the MP joint, it's a little more sloppy. It probably would tolerate that fine. But I don't know. I think I'd do an intra-articular. But it's intriguing to think about what you said. I'm going to think more about it. It's kind of a cool idea. All right. What happened?
This is what happened. Largely a very similar description. I'm sorry that this is grainy, but this is the window, the side window over that. And this was the fixation that was chosen. And this patient actually did very well. I use screws sometimes. I very rarely get fortunate enough that the fragment is big like this. Sometimes it's just the condyle, and I don't get to put, larger pieces of screws in there. But this was his motion 6 months out. So I thought that was a pretty good result for this type of injury. And I don't think that they always, at least in my hands, and again, this is Dr. Kiefaber's hands, but they don't always turn out with this good a result. But I think sometimes you can hit a home run with these. It's an interesting case.
That's interesting. So could you go back to the x-rays for 1 second?
Mm-hmm.
So we just the distal screw. So
big,
the head's big. I try to use smaller screws. I try to avoid the collateral ligament if I can. And you saw one of those one of the cases, I used a K-wire in a very small screw. Mm-hmm. I try to avoid, if you have to use a big screw, if you make a slit in the ligament without cutting the ligament, you can eat the head in. But it's big.
Yeah, I think there was no more of the thinner ones in the set, maybe. But so yeah, I mean, I think that this is an interesting outcome for something that, if you do a few of these, you might not get this much motion out of it, especially if a patient has a lot of pain afterwards and doesn't move it sort of early on. Well, I think that we're at the time. So unless there's, Jeff, do you have any other questions in the queue?
So one more question from the audience. Chuck, treatment for patient with a metacarpal neck, gunshot wound, and a soft tissue defect. So any thoughts on combined coverage and bony reconstruction?
Yeah, I had a case of that I didn't include. So in terms of soft tissue, the dorsum of the hand is very well vascularized. So what digit is it? Index? Or did they say? It doesn't matter.
Didn't say, but index. Yeah.
So you could use a metacarpal artery flap there. You could use some adjacent tissue if you're not that comfortable with with dissecting around vessels. You could just do a rotation flap to cover that and skin graft the defect because the skin's pretty pliable. So to me, the soft tissue is probably not that much of an issue. I would make sure you do adequate debridement, and then I would put a bridge plate on it, depending on how big the defect is. So you're gonna put a cement spacer in. You could use some intramedullary K-wires. That's been described. My preference now is to use a bridge plate. So it's going to go on to the proximal phalanx. We accept the fact that we're going to do another operation, take the plate out and do a MP capsulotomy, but it's stable. You don't have to worry about, the limited fixation that you have in the head, and you don't want to burn a bridge and then go back in and graft it and then take the plate out and do a tenolysis. Capsulotomy. And
then what's your time course to taking out your cement spacer, bone grafting, and tenolysis? When do you do that second stage?
Ideally, like Mascalais, 4 to 6 weeks. You can do it later. So the soft tissue envelope probably is going to be the determining factor. If I'm comfortable with how that looks, then I would go in for 4 or 5 weeks, bone graft it, and then I would leave. I wouldn't worry about it. If you could convert it to fixation limited to the metacarpal, that would be good. If there's enough head, I would use a locking T-plate. As long as it's proximal to the articular surface, you could do that, but you got to be confident that you have stable fixation. Otherwise, I just leave the bridge plate on. And there are a couple companies that make long mini fragment plates, long straight mini fragment plates that you can span long areas with.
Well, do you have any more, Jeff?
All right. I think thanks, John.
I just wanted to ask Chai. I don't know if Chai's on still, but Chai had that intramedullary fixation of the proximal phalanx malunion.
Yeah.
You want to comment on that? It's a unique approach.
So I've been called lots of things, but never been called king of anything. But that's okay. Thank you. That case was unique because the patient had a condylar malunion, and the articular surface was already affected, which is why I chose to go from there. And it seemed to me that doing an intramedullary would afford him the quickest return to motion. As Jesse said, you want to fix it stable so you can get them moving. And I felt that going intramedullary, because his articular cartilage was already affected, so I was not doing anything to healthy cartilage in that sense, So that's the reason I took that route. And the tension band just stays there. I think it's the most underutilized thing in hand surgery, a good tension band. It's such a good bailout. So it's good anti-rotation also.
I was going to say the same thing. Anti-rotation for that one is important.
Yeah.
Great.
Well, thank you all very much. Thank you to all the participants, and we hope to see you again soon.